Good evening, everyone. Thank you so much for joining us. Sorry, we had a few little technical issues there, so we really appreciate your patience and are really pleased to see you tonight for this webinar on suicide prevention, working with older people. I'll just start tonight's meeting by acknowledging the traditional owners and custodians of the lands on which we all meet today. I'm here in Bathurst on Wiradjuri country. I pay my respects to all First Nations people and acknowledge elders past, present and emerging. I recognise the continuing connection to land, water, culture, and I warmly welcome all Aboriginal and Torres Strait Islander Australians who are joining us this evening. And thank you to everyone for joining us. We're really glad to see you. I'll just a little bit of housekeeping before I pass over to our presenters. Tonight's session is being recorded, so if there's any colleagues that haven't been able to dial in tonight, we will make this recording available to them. We're also really encouraging interaction and questions. So if you've got any questions or want to comment throughout the presentation, please pop your hand up. We welcome any comments throughout, but also very happy for you to put questions in the chat and we will address those either as we go throughout the presentation or at the end of each presentation. So tonight we're really pleased to welcome Gabe McNamara and Martin Davis here to present to you. Can't see their introduction slide, but Gabe, I might pass over to you and you can give a bit of an introduction to yourself if you're happy to share your screen.
Sure. I'm Gabe. I'm the District Coordinator for Older People's Mental Health, and I am just about to share my slides. Hopefully that comes through there now.
That is perfect, Gabe.
So hi, Yama. I'm Gabe. As I said, I'm the District Coordinator for Older People's Mental Health here in Western New South Wales Local Health District. But I'd also like to give credit tonight to Dr. Lindsay Airst, who couldn't make it along this evening, but she's the clinical lead for psychiatry with older people's mental health. And without her, we wouldn't have brought this content together. So the slides are in collaboration with both of us presenting to you tonight. Thank you again, Katie, for the warm welcome and introduction. The aim of our presentation this evening is really to provide you with an overview of the older people's suicide prevention pathway in Western New South Wales LHD and talk to this, to share current evidence-based practice in relation to suicide prevention for older people and with older people, demonstrate that relationship between suicidality and mental health conditions, as well as depression in older people, and showcase some of the services and supports that an older person experiencing suicidal crisis, but also their family, carers and support networks can access. Firstly, a background as to why older people's suicide prevention. In Western New South Wales Local Health District, we recognise the importance of suicide prevention in older people in Western New South Wales. We know worryingly that older people, in particular males, 85 plus, have the highest rate of suicide, of death by suicide. And according to the Centre for Rural and Remote Mental Health, people living in remote Australia are up to twice as likely to die by suicide as those in major cities. Unfortunately, the rates of suicide increase with remoteness, and we have seen increasing presentations to our local health district services since COVID and as a result of COVID of older people, particularly amongst older people, that rise in presentations. We know too across Australia that 10 to 15% of older Australians experience depression, and this percentage jumps when we look at older people residing in residential aged care. The Western New South Wales PHN reported significantly higher rates of suicide evident in the older population within Western New South Wales when it was compared to that state average. We also know that Western New South Wales is uniquely placed in that 12% of our population identify as Aboriginal people, and communities are made up of a significant proportion, and more so since COVID, of people who identify from cultural and linguistically diverse backgrounds. So it's because of all of these factors that we felt the need to formalise a whole of system approach that acknowledges roles of all primary care services, all aged care, health and mental health services, and the crucial roles that they play together within Western New South Wales in supporting older people around suicide prevention. There's quite a bit of research that I'll talk to and touch on tonight, but the pathway and the information around suicide prevention around older people has really come from an impetus from Ministry of Health. It's come from also the Uni of New South Wales and their older people's aftercare service delivery model, the Towards Zero Suicides initiatives, which Martin will talk to later this evening, and Roses in the Ocean paper that had some earlier consultation to better understand the specific needs of older people in regard to suicide prevention services and supports. But firstly, let's do a bit of a deep dive into the research itself. So suicide rates in older people, awareness, identification and engagement are important. The evidence shows that in men and women across all world regions, that rates of suicide mortality are highest for the oldest age group, demonstrating that there is an increasing impact on the oldest old. The highest rates of suicide per 100,000 are in older men. So as mentioned earlier, males 85 plus experience that highest rate of death by suicide. Suicidal behaviour in this population is with greater intent and lethal means than other age groups. And if we generalise for a moment, older people are more likely to live alone, have less social interaction, less likely that others may connect with them, and so be aware of that older person's thoughts, their feelings, their actions, and their experiences of grief and loss. Are compounded too at times. Older people are more likely to be frail, impacting again the ability for them to possibly be out and present in the community and engaged. We know that social isolation is almost considered the kind of new smoking in terms of health promotion at this point in time. And we know that because of frailty, the impact that self-harm can have is that it can likely lead to more lethal consequences. The impact, again, physical health and chronic pain can also take a toll on an older person, and all of these have a complex interplay and adversely impact that older person. In 2019, depression was associated with a significant proportion of suicides in Australia, 37.9%, and the references are as per below. So if we touch on depression here for a moment, depression is highly prevalent in older adults. It's often underdetected and underreported. We know that older adults are more likely to report somatic or physical complaints of depression, such as poor sleep, weight gain, pain. At times, they might report feelings such as guilt and sadness, but these aren't characteristic. And in a study by Sunderland in 2015, 1 in 20 older Australians met criteria for depression and or anxiety in the previous year. Rates are higher in women, but the gap narrows with age, with the oldest old. There's higher rates of depression in medical inpatients, residential aged care settings, and those who experience physical illness. So for example, if we look at Parkinson's disease, 20 to 40% of those who have a diagnosis of Parkinson's disease also have a diagnosis of depression. And in primary healthcare settings, it can be as high as 25% and 50% in aged care settings. In a local study too, there was a study in Dubbo of 336 Aboriginal Australians aged 60 plus, and there was 10.4% that rated suicidal thoughts in the last 2 weeks that strongly associated with current depression on the rating scale that they used. But for more information, certainly have a look at Shen et al.'s research in 2018, and the references are at the end. This slide's just to represent the different types of depression that are present, that are also present in the older people's population. So there's major depression. There's later onset, which is depression that occurs among people who are 65 and above with no previous history of depression. There's a continuation of major depressive episode, that of substance or medication-induced depressive disorder, where symptoms occur as a physiological consequence of the use of substances or medications. It can be due to another medical condition. It can be the likes of cognitive impairment, so dementia or mild cognitive impairment with depressive symptoms can be evident, and some signs of dementia may strongly resemble those of a major depression, so such as social withdrawal, lack of interest in self or in others, low initiative, poor motivation, and the diagnosis of depression may be made more difficult when dementia has not been recognised before. Certainly depression is a risk factor for dementia and for mild cognitive impairment, and depression is also associated with an incident of mild cognitive impairment. And then there's bipolar affective disorder. But, I should say, major depression is a clinical diagnosis. It's not only a feeling of being sad or distressed. It can be in the context of recent stresses. There's clinical research in depression and major depressive disorder when someone has had more than one episode of major depression. Keeping in mind, depression is one of the most significant risk factors for later life suicide and attempts. But no depressive features are specific to an older person. Some studies have shown, however, that there are higher rates of an older person experiencing psychomotor changes, psychotic symptoms, an increase in severity of depression and or anxiety, and cognitive impairment. And as I mentioned earlier, older people present less commonly with complaints of low mood and more with those somatic complaints, especially about gut, pain of muscles, joints and bones, and memory issues. So let's consider self-harm for a moment and its impact. Self-harm, which is any self-injurious act carried out by a person regardless of intent. It may be direct, but you may also, particularly with older people, see indirect signs. So for example, a person may refuse to eat or drink. Factors are complex and even more complex when someone is experiencing cognitive impairment or dementia. Most studies, there are few studies around this area. However, we know that cognitive impairment and dementia are associated with an increased risk of hospitalisation for self-harm, particularly in older people, and worse outcomes. The higher rate of coexistent mental health conditions suggests that interventions which reduce BPSD, behavioural and psychological symptoms of dementia, might reduce self-harm in people with dementia. So there is quite a background of research, and I've really chunked it all together there tonight, related to older people, to suicide, to self-harm, and to mental health and its impacts and effects. And based on this research, we wanted to make a positive change working with older people in Western New South Wales to a more streamlined approach to care. So kind of bringing us out of some of the really concerning stats and research. We, in January 2022, were successful in being selected to participate in a clinical redesign project to develop a local district pathway. Importantly, the Ministry of Health really chose to focus on older people as a priority group because of that high rate of suicides per capita, especially in the oldest olds, that 85 plus group. All credit, as you can see here, goes to the efforts of the project user group that we brought together, which comprised of not only older people's mental health clinicians, but those with lived experience, senior clinicians within mental health, drug and alcohol, aged care and PHN all came together to play a part to develop what you'll see tonight. And across a large geographical spread as well, and communities. And then they connected and collaborated with communities across Western New South Wales to get that feedback to what you see. The pathway and the purpose of this pathway is directly related to us in Western New South Wales wanting to have a clear and most direct pathway for an older person to access care that might be suicidal. For older people, their families, carers and supports, to experience something that is collaborative, that's culturally safe and that's integrated, that's an integrated pathway for suicide prevention, that's inclusive of all people and population groups across our district, and that facilitates a smooth transition with and between services because of our complex connections. It's something that staff, in that feedback, we wanted to resource our staff to equip them to make quick, informed decisions about a person's care and with those people, their families, carers and communities, but also provide that person with the right care, the right time at the right place. So as we step through the pathway, I'll talk to the evidence at each section. Importantly, the pathway is based on the Australasian Towards Zero Suicides framework, and it's shown here on the left-hand side of the screen, on that far left in those arrows. Identify and engage, and it flows through to transfer of care. So from what we talked about earlier, it is crucial that all staff are aware and can identify and engage that an older person, their family carer, can present to any service and receive that welcome and connection and support. It links back to the research that shows how important it is to identify and engage with someone, an older person, at that first point, because they may be less likely to be upfront about that suicidal thinking and more likely to describe those physical symptoms again, such as poor sleep, weight loss, pain. When we spoke to communities here, a couple of points that did come up that they raised were about how to speak to an older person if they, as a loved one, are concerned about mental health and well-being. And there are some great resources Beyond Blue. Beyond Blue has one, which Martin will reflect on later tonight. The other thing that people were concerned about was that if a person directly spoke about suicide, it might give them the idea. And research shows that asking the question, even an older person, about if they are thinking about suicide won't lead them to this. However, the fact is that it's often a relief, and this came out of the Roses in the Ocean, a collaboration, that talking about suicide not only reduces the stigma, but it also can be a relief for someone who is experiencing suicidal thoughts to know that someone cares, listens, and is asking the questions. The next section of this is around suicide safety assessment and planning. And in consideration at this point, it came back from the consultation and the project group as important to reference a general medical review here, and that if delirium is present, certainly screening for that too, because often what can happen is acknowledging that presence of a physical illness shouldn't detract from a mental state exam, but equally important that the presence of a mental illness not take away from comprehensive medical assessment. Both need to be considered hand in hand. Strengthening that assessment with collateral information, that from families, carers and support networks, is important here too. And Martin will talk to the tools later on tonight that can be used to assist in assessment and brief intervention. And these tools don't take away from an experienced clinician or clinical judgment. Although we do know from research that having validated ways to assess, plan and offer brief intervention is important. And so then from here, the decision points lead from brief intervention to more options. And those options extend, and it's about least restrictive care and decision making of the most appropriate pathway for the person, the family carer, the team, and the supports at the time. There are the clinical and more intensive pathways, the left and the middle, so looking at the community older people's mental health service pathway, and the inpatient care pathway, which is a medical or mental health inpatient care pathway. For example, I guess here that with community older people's mental health, we have services across the district, and a person may seek this pathway if, or they might be considered for this pathway if they are acutely suicidal, but can continue to be safe and supported in their community with that clinical input. It may be that the older person lives in a town hundreds of k's from a mental health inpatient setting, but they have some strong family and support networks such as their GP around them, and the older people's mental health team agree that they can provide that intensive support in the community instead of creating that added impact of distance, travel, burden to the family, the carer and the person themselves. There is also the pathway for someone who, it's a non-clinical pathway, it's less intensive for someone who may remain in the community who doesn't need a clinical input at that point in time. They might be engaged with their GP or with an Aboriginal medical service and have strong supports there in that primary health care network. This pathway is important to acknowledge because it does show least restrictive care, and it shows that brief intervention can lead to good outcomes for someone who doesn't need that clinical input. But importantly too, that if things change, those cross arrows show that there can be steps up or down in care as required. From there, I guess the point of difference between brief intervention and treatment is that brief intervention is that first response. It's short, it's less intensive. It helps decide the next part of the path with the person. It's purposeful and targeted. Whereas the step up from that is treatment, where it's taking that a step further. It's more intensive with that person. It requires more elements to be thought about and connections with services perhaps. And so in older people's mental health services, forms of therapies might include cognitive behavioural therapy or dialectical behavioural therapy. It might include reviewing housing, ongoing counselling, community activities, links and referrals with other services with the person rather than just connecting to. It might even think about supports around medication and other services in place. And a key thing to note here with our older people's mental health therapies is that work and collaboration with families and carers and the support networks such as the GP. because we really know that older people often have more complex and varied needs across physical, mental health and psychosocial domains. In an upcoming slide, I will refer back to some of the services that we work alongside and talk to those in a little bit more detail. But the other last piece of the pathway is the transfer of care. And the key points here to keep in mind are that current safety plan goes with the person, that there's that shared consent to share it with other services and be a connection point for everyone. It's more about not just a written referral, but a person-to-person link between Western New South Wales LHD services to other services, to that referring service that are taking over care. We know that person-to-person communication and that having a conversation about with the person and with the services that are being referred to about what to do if a person doesn't follow up are important. So there's that link back in to additional supports, and again using that flow through of step up, step down care. And the importance of being able to connect back in with services like our older people's mental health community teams or with our mental health emergency care service. So just to touch on some of the services and supports briefly and take a closer look at what those look like for an older person in Western New South Wales, for their families, their carers and their support network. MEC is one of those, the Mental Health Emergency Care Line. It offers that professional help and advice, as well as a referral to local mental health services. It's staffed by mental health clinicians who will ask questions to determine if a person needs ongoing mental health care and how urgently it's needed. The mental health line is available to everyone across Western New South Wales. It's available to the person themselves, to the family, to the carers and the support network. So it is available to GPs, to Aboriginal medical services, to residential aged care facilities, to anyone who, any clinician, non-clinician seeking advice, consultation, anyone who's concerned about someone's mental health. And that's the 1800 number. So 1800 011 511, and it's 24/7. There's also safe havens, which Martin will talk more to later. But in Western New South Wales, we have safe havens based in both Parks and Forbes. And they provide a service for older people. And then there's the aged care services. So aged care services within Western New South Wales, the aged care team coordinate a range of services for older people, including outpatient geriatric medicine services, comprehensive assessments by clinical and non-clinical assessors in hospital, community and residential settings, dementia counselling and advisory services, and out-of-hospital non-clinical supports for people leaving hospital and those requiring end-of-life support. There are, importantly, two other services outside our local health district, including Catholic Care Wilcannia Forbes. They have a family and carer mental health program, and this program provides education, individual support and advocacy options for people caring for someone with a mental illness. So not just older people, but includes older people. There's Lifeline Central West, which includes 13 Yarn. 13 Yarn is a service designed and developed by Aboriginal people for Aboriginal people, similar to the general Lifeline 13 11 10. I think I've got that number right. But Lifeline Central West has been supporting individuals and communities across Western New South Wales, and they provide assistance such as financial and gamble aware counselling supports. They support through rapid community support programs, such as through critical incidents in the community and the crisis lines, and they build knowledge through workshops, including mental health, wellness and suicide prevention. There's standby support after suicide, And standby support after suicide is a postvention service. It provides free, confidential, practical, holistic, non-clinical support to anyone living in Western New South Wales who's been impacted by suicide. There's no restrictions on who can access the support. They provide support to individuals, to family and kin groups, to groups such as workplaces, to schools, to whole of community, and they provide emotional comfort and psychological first aid. They also offer workshops, and anyone can refer to standby for support, and individuals can self-refer. There is also NALAG, so the National Association for Grief and Loss. NALAG deliver a range of loss, grief and bereavement services. They are based here in Western New South Wales, and they provide that free confidential grief and loss support. It's delivered by a team that are trained volunteers and staff, and they have options face-to-face, Zoom and phone supports in some centres. I think their centres here are in Dubbo and Mudgee, and they can provide additional information and resources on grief and loss and ways to support older people experiencing loss. RAMP are another, so the Rural Adversity Mental Health Program. This provides information and education and resources to connect people in rural and regional communities with appropriate mental health services and supports, and they do respond in times of disaster and severe adversity as well. DSA are another, so DSA are Dementia Support Australia, and they work in partnership led by Hammond Care that brings together dementia expertise from across aged care. They have a free national service that operates 24/7. It's not specifically suicide prevention. However, they do assist anyone who calls them around what signs of depression and anxiety might look like in dementia and consultation support in that area. And they provide services to support the family, the carers, the person who's experiencing dementia, but also those support networks being through health, through aged care, through primary health services. And they're a link to the Specialist Dementia Care Program. The last one I wanted to reflect on tonight was the Brother to Brother hotline. So it's an Aboriginal men's crisis line, not specifically for older people, but for Aboriginal older men. It is a valuable service. They provide phone support for Aboriginal men who need to talk to someone about relationship issues, family violence, parenting, drug and alcohol, struggling around coping for other reasons, and the line's staffed all by Aboriginal men, including elders who have a lived experience in issues that they provide support with on that line. The last thing in the pathway itself, and at the back of the pathway, is further information. It elaborates on some of those key points for those who want to seek more detail, and it expands on some of the acronyms and abbreviations that we use in the pathway itself. And so if you do have any further questions, please reach out. You can use the chat box tonight or get in contact with us via our details here. There's resources and references that I've attached to this presentation at the end, and you'll receive those shared in the slide pack to follow. But thank you again, everybody.
Thank you so much, Gabe. Did anyone have any questions that they wanted to ask? Please feel free to pop off mute, put your hand up and ask. In the meantime, we could probably have Martin get his slides ready. I think you've covered everything off perfectly there, Gabe.
Thank you, everyone.
So if there aren't any questions, I can't see anything there in the chat. I'll just check for any hands up, but I can't see any. We will now pass over to Martin Davis to share his presentation with us. Thanks so much, Martin.
Thank you very much. So good evening, everyone. Just a slight word of warning with this talk. I do talk specifically around means of suicide. But I'll introduce myself first of all. I'm a mental health nurse by profession, only I'm the district coordinator, as you can see, for the Towards Zero Suicides initiatives, which includes those safe havens that Gabe mentioned. So what I'll talk to this evening is looking at screening and safety planning as part of our pathway. And Gabe had mentioned the Beyond Blue info sheet, which is you can Google about engaging with people, older people who may be suicidal. And I'll take you through that Ask Suicide screening tool that we're going to adopt rather for the pathway, and how we complete a safety plan. And the interesting thing for you guys is at the end of the talk, I'll take you through one case study before I'll ask you to get involved with a second case study and look at how we might safety plan for that person. The talk comes with a mini disclaimer that the views and opinions that I profess to don't necessarily represent those of the service that I work for, Western New South Wales Health. And I do want to give my thanks to Dr. Lisa Horowitz, who is the founder of the Ask tool, and Tony Pisani, who gave a lot of tuition to the Towards Zero Suicide coordinators around suicide prevention training. Here's some evidence. This is the largest study around the suicide prevention pathway. This was on the Gold Coast. They looked at 10 years of presentations to emergency departments, several emergency departments, for people that had what they identified as a first suicide attempt. And these persons at that time weren't put on a pathway. So they then looked at another year of presentations, over 600 people going into the ED with their first suicide attempt. And these guys were put on a pathway. So that pathway looked at, as all people going through an ED, there would be a triage, but that would be followed up by a coaching tool to ask directly about suicide. There'd be a risk formulation. The brief interventions included the safety planning, and that's actually starting to happen in some of the EDs across the state now because of this info. Very importantly, when we safety plan, we look at reducing access to lethal means, and I'll talk to that a little bit later as well. And a rapid referral, of course, to our community services that might include other people outside of health as well, and structured follow-up, which means that people get the care that they should be afforded. Transitioner care talks about a term called warm handover, where if I was working at mental health emergency care, for instance, and I was referring someone on to another service, I would be saying to the person at the other end, whether that's a GP, a psychologist, or a non-governmental organisation, can you give this person an appointment? Thank you very much. Only if they don't show up for that appointment, can you please give me a call back, because we'll follow up and we'll take back over care. Couple of pointers. Asking about suicide on its own is not a risk assessment. It's a guide to lead the way that we ask those questions. Now, the real positive outcome from this for older people, that it reduced people's harming and returning to emergency departments by 95% in older people, and that went right up to 90 days post the initial presentation. This is our suicide prevention framework. it looks very similar to the older person suicide prevention pathway because it's also based in the Australasian and US suicide prevention strategies. So there's these 4 modules that spell out the word care, and they're connect, assess, respond, and extend. So in connect, Gabe talked to the engagement being such an important part of what we do here. So asking directly about suicide, but asking at the right time, you know, not from the get-go. We clearly want to engage a person and have them trust us to the point where they might actually answer those questions. And then the collaboration with family carers, the person themselves being at the centre of their care, collaboration with other services outside of health perhaps, and us committing to a person and their family to say, we're going to be with you through this, we are going to get you through this, and with the supports that you have, I really do truly believe that you can feel better about this. We safety plan as part of this, identifying 2 foreseeable changes. So if one example would be if someone's having relationship difficulties, we would say, what would you do if your partner was to actually leave you, and come up with a contingency plan to keep the person's anxiety lower than it might be without that contingency plan. Here's the Beyond Blue document. I've really just condensed this to a slide to look at how we learn about depression and anxiety in older people, to give us a better understanding about what we're looking out for, and giving the person the respect that they clearly deserve around understanding things from their perspective. We talk about in mental health about suspending belief and recognizing what's going on for the person is real and true to them, and of course valuing their wisdom and experience. Gabe mentioned the risk around placing people into care and how the risk of suicide actually goes up if you either place someone into a care home and take away their independence, or for that matter, if you admitted them to hospital. Some people have to go into care, some people have to go into hospital. That's acknowledgeable. Only we do our best to try and work with the person to what they feel is the best outcome. The best way of explaining how we talk to people who are suicidal, particularly older people, is to be culturally sensitive, speaking plain English or the language, the first language of that person, and not using a great deal, if any, medical jargon, for instance. But the old term, "Are you okay?" You know, you don't quite look at yourself. I'm a bit concerned about how distressed you look to me, as opposed to when I saw you last week. But giving people a sense of hope. This was such a big thing through the co-design, that people wanted to have that instillation of hope around that you will get through this if we work together, and we work with your family and your friends for that matter. The Ask screening tool, this is a Navajo version that I'm going to take you through, and the reason why I mention that is that some of the language in the original tool, which is still on some of the slides here, was quite triggering, well, very triggering for people with lived experience and generational trauma running through their families. So they've dampened down some of the questioning, so they're not asking somebody, you're not asking somebody, do you want to kill yourself? You're toning it down, but asking the same question in a different manner. Now, anyone can ask these questions, but the Ask team do suggest that a clinician leads this, and you could have a peer worker, a person with lived experience, sat alongside the person to support them and understand what questions are going to be coming. But what you don't do is ask these questions in front of a loved one, unless the older person is adamant they want their wife or their husband to stay in the room. We would actually politely suggest that the husband or wife or partner actually leaves the room. And what we wouldn't say is, Mr. Robinson, would you mind if your wife steps outside for 5 minutes? Because that puts the onus and some of the stress back on the person. So we'd take the lead really, and I'd say to the partner, would you mind stepping outside for a moment? We won't take long, and we'll bring you back into the room. That's going to reduce some of that guilt and shame that the person may have in front of their family member, one would hope. So here's the 4 questions that we ask everybody. And that the first one being, in the last few weeks, have you actually had thoughts about ending your life? And you back that up after obviously hearing what the person has to tell you. A question around their contextualization around what the family would think about this. So how would you feel if you were to end your, how do you think your family would feel if you were to end your life? And then you narrow it down to ask about, in the past week, have you had other thoughts about ending your life? And of course, pause for the response again. And have you ever tried to end your life? They'll tell you a little bit about that. That gives you a heads up as to where you need to look for old notes, etc. Now, they first tested this and validated it on younger people who are very upfront and honest, I've found, in emergency departments, and around 9% of younger people, and this was all people presenting to hospitals, people with a sore thumb or a broken leg or a mental health concern, and around 9% of those people said yes to one of these 4 questions. Now, if you get a yes to one of these 4 questions, you ask a 5th one, and that is if you're thinking about ending your life right now. And if that's a yes, then if you're not going to be able to provide a comprehensive mental health assessment, you can politely stop the interview and say, well, I think we need to get you some help from mental health services, and I'm going to see who might be able to see you today. Now, the good news is, with those young people, only 0.3% of people answered yes to this 5th question. Now, that tells me this is a strength-based lead to where we go with the next set of questions. If they've answered yes to one of those 4, or if we're continuing the review, we validate the person's distress. We acknowledge that it's there. We'll not suggest that we know exactly what's going on with someone's level of distress, but we can see that it is going on. And we can praise the person that they've taken this big step to come out with things that people often don't like talking about in front of complete strangers for obvious reasons. So we use some coaching skills in those brief interventions, when one of them is called gentle assumption. And rather than asking somebody in the last few weeks, have you thought about ending your life? This is the subsequent questions. You've already asked that question, of course, but asking them how many times they've thought. That gentle assumption to say, I feel you've probably thought about this more than once. We try to normalize the thinking, reducing the shame that is attached to people often when they're suicidal, and that can be done if you've worked in an emergency department by saying, I've seen quite a few people tell me similar things about their distressed and suicidality, and I know from talking to those people that it can be really difficult to talk about. So thanks a lot for telling me. I really do appreciate it. And then we offer radical empathy and radical hope. I can see you going through a lot right now. I do believe, however, with the right support, your family and friends, we can get you, excuse me, and you will feel better. Now, this is I'm not going to take you through all of this document, but these are all available online. You'll get the slides and you'll get the lead to the websites. There's some really good videos on there as well around how the tool came about. But this is a follow-up, a little longer assessment. The first one takes around 2 minutes. This one takes about 10 to 20, depending on the responses. You've already praised the patient, and then you assess the person's suicidality in what those thoughts mean to them, how often they've been, if the person's got a plan. Now, if the person's saying they're thinking about suicide right now, you again would suspend the interview and go to looking at where the referral to mental health might lie. And with planning, even if someone says they haven't got a plan, you do ask, if you were to end your life, how would you do it? How would you think you would do it? And the more detailed the plan and the more lethal the likelihood of the result of the plan, the more concerned we should be and be getting a full comprehensive review very quickly. We look at past behaviour for a whole number of things. One of the biggest precursors to suicide is people that have actually harmed themselves or attempted suicide in their past. And as importantly, it's important to ask, well, what did you do? What was you expecting to happen? Did you actually seek any care from what you did, or did your family take you against your will into emergency? And what was helpful about the care that you received as a result of that, and as importantly, what was not so helpful? Again, I won't take you through the whole of the symptoms here, but it's important to recognise that the way that we assess suicidality is different to the way that we might interview somebody for an acute mental illness, for instance. We'd still ask about appetite, mood, energy levels, sleep patterns, but we also ask about impulsivity, if the person is becoming more impulsive, if they've raised the amount of alcohol or drugs that they're using, if they're feeling more isolated, referring back to what Gabe talked about, and do they come up with some wording that you would hope people would not generally use in their life, which is, I feel hopeless, I feel shamed, I feel so guilty for what I'm doing to my family. Just coming back again, we round that off with looking at social support and stressors, and we recognise that in times of great struggle, some things that normally would be of help to a person might be actually something that's quite concerning about the person. An example would be with the family. If they're falling out with the family, or they're getting very irritable with people that would normally be very warm towards, we need to be concerned. We very delicately ask about elder abuse in older peoples, and there's some signs which I won't go right through, but that we look out for with regards to, has a person become more isolated? Do they look more depressed to us? And you can see there's some other stressors there. And from that, we look at means restriction, and the way that we do that, if we've established that somebody has been thinking about, say, driving their car and intentionally crashing it, we'd look at, well, could perhaps your partner or your next door neighbour or somebody take hold of your keys, at least till things have improved for you slightly, and make sure that the person that you're asking to take the keys off the person has done so. And that would be the same with medications. It would be the same with a rope in the garage. It would be the same with guns and gun cupboard keys. And then, as I say, determining the disposition. Now, if you got to this stage of a semi-structured review such as this, you're going to have this person seen by somebody, aren't you? But whether that's an emergency straight away, that doesn't necessarily mean the case. But typically, we would say that you're looking at bare minimum 48-hour follow-up, or if the person's got an amazing GP or psychologist, perhaps they'll see them the following day. And give them a list of those names of the emergency numbers. I will pause and see if anyone has any questions. You can bring yourselves off mute, and Gabe and I will be answering some questions at the end as well. So safety planning. We in Western want to see this occur wherever possible for the majority of people that come into our services. Some people in those safe havens decline to safety plan. It's quite confronting to talk about all these different stresses that are going on in your life, but about a third of people are safety planning at the moment, and we want to improve upon that. So there's a couple of apps that I'm going to show you. Up in the top right hand corner, this is Your Crew for Aboriginal people in Aboriginal language, that looks at putting a safety plan onto your phone, for instance, and then we use the Beyond Now app in our safe havens, for instance. And this young lady on the right, this is ideally how we like to see someone who's tech savvy, utilising a safety plan by actually putting in the information themselves with the person that's supporting them sat alongside them to tease out what could go into that plan. Everyone on the plan should be consulted. So if the person wants their partner or a friend or a neighbour, as I say, involved, then that person would get a copy of the plan. And of course, our emergency services would likewise get a plan. And we encourage the person that's completed the plan to put it up on their fridge, or obviously take it with them if they're going into the emergency department. Amendments are made if the risk changes or if things improve for the person, we can change the plan. And the picture below is we do use some hard copies for people that aren't so tech savvy, and we'll sit down with the person and complete them alongside them once more. So here's the first 5 of 7 parts of the plan. The start talks of early warning signs. So those signs that a person's seeing that aren't quite right, that they're things that show that the person's struggling. And you've got some examples on the right-hand side of what they might be. They're personal to the individual, of course. We're not going to impose those onto somebody. We're going to wait for them to tell us what are the things that you're seeing at the moment that are really concerning for you. Now, I wouldn't give people, I think there's 8 things in that first suggestions plan. I'd reduce that to the top 3 with the most stressful thing at the top. And then we'd look at those foreseeable changes. And we like to find 2, and there aren't always 2, of course. There might not even be 1 if the person's so distressed and withdrawn. But we like to think if we can come up with 2 contingency plans, should these changes actually occur, perhaps if a third contingency plan, if a third change came, an unforeseeable plan, then they could utilise some of those mechanisms to get the anxiety levels down again. So looking at reasons to live, and some people don't see any reasons to live, but if they do have a lovely pet at home, if they've got a best mate and a brother or a sister that they love, a family, a grandchild, then we try to pick up on that. And again, I would place the most strongest reason to live at the top. So that's the first thing that they look at when they check the plan. Making the plan safe is, as I say, reducing access to lethal means, and looking at what a person can do by themselves. And again, I'm not a fan of saying, well, how's about going for a walk? How about taking a bath or a shower? But I like to ask the person, first of all, what do you do normally when you do start seeing that tension building? And if the person's got nothing they can think of, you can give some evidence as to why. You might say a bath or a shower might help you at night when you can't turn off. You know, you go in the hot shower, you come out, you cool down, and with that, your heart slows down, and so does your brain. And sometimes people find that useful for getting off to sleep. So give a bit of a backup evidence to why you're suggesting these things. People and places, you could have a mixture here. There should really only, again, in these boxes, 3 tops really, if you can find them, rather than having about 7 different people put in there. But perhaps say your best mate or your brother, or perhaps even your best mate and somebody from the church, and give them some options as to who they can connect. Sorry, I've got ahead of myself. So people I can connect with, looking at connectivity and how that forms such a strong hold in reducing people's safety. So looking at what people can do. And I do apologise, but the next part is, who can I yarn to? Who can I talk to? And that might be professionals, but it's as likely to be friends, family, and people that can connect with the individual. And lastly, again, I wouldn't give all those different numbers. Obviously not going to give a kids helpline to an older person, but I'd narrow that down to 3, maybe 4 tops. And probably the priority might be mental health emergency care at the top, then Lifeline, the men's line, for instance. And you can put photos onto the app, because this app on your phone lets you download, and these are my friends and family in Australia. And then when I look at my phone, because I always show this picture on the right hand side is of my hand and my phone, I show people I've got this app. I feel it works. You know, the pictures alone bring me some comfort when I'm not having the best of days. So let's go through Jack. This is Jack. He is a 72-year-old retired former electrician. He's divorced. He lives on his own, but he's got a really good mate, Tom. And he's called Tom to say he's thinking about ending it all. He admits to recent suicidal thoughts and spending most of nights alone, worried about being evicted from his property. We're having lots of people in this time coming into our safe haven saying this. And he works part-time at the Hospital Volunteers CAF, but is missing shifts. He has a loving family. These are his strengths. He's got 2 beautiful great-grandsons and a brother, Barry, who he's very close to, and that's important that they have got that connectivity. He usually loves walking his dog, Rupert, and he normally goes swimming twice a week, but we'd ask him, well, when was the last time you went swimming? He likes fishing with friends and is an avid rugby league fan. His GP has recently prescribed him an antidepressant, and he sees a peer worker, which is another great strength, of course, in the community. So I'll formulate this myself. You're going to formulate the next one, if you would, please. What else do we need to know? Well, he's spoken about ending it all, so we really do need to know what that means. Whether he has got a specific plan, where he's thought about specific means and how frequently he's thought about them. I'd ask him, you know, if you're thinking about driving your car, have you actually got into it and started it up with the thought of actually doing that? What are the risks? Well, there are many, aren't they? He's an older person. He's retired. He was an electrician, so he knows about electrics, and we are very mindful of people in the trades services and their high rate of suicides. He lives on his own. He's isolated, and he sounds depressed to me. And he's at risk of all different things happening, including losing his job because he's missing shifts and getting evicted from his flat. So that's brought me to think about what those warning signs might be. We know he's been tearful. He's been waking up early as we've asked him those other questions, and he's not eating all day. So that was his top 3 stresses and signs that things were really not travelling too well. And he has practically given us those foreseeable changes that he gets evicted. So if he was to get evicted, we'd ask that he go and stay with his best mate. And together, because Tom knows this as well, they both call mental health emergency care and say, it's happened. And our carers would step up the amount of care that's being provided and the frequency of that care. The other one is that he could lose his job, of course. And the plan, the contingency is that his brother would give him a hand, and perhaps they could even walk into Vinnie's and see if he could get a job there. Now that's clearly not as easy as it always is. As I say, sometimes you can't populate that first box, including the second box as well. But he does recognise that the reasons to live, his prime reasons, is his best mate and his brother, who he's so close to. And he's seeing his great-grandsons grow up, of course, and his dogs. I always ask people about their dogs' names, who they are. Have they got any pictures on your phone? It really does form that alliance of what the bonding is with our animals. And we know he's a fisherman. That was one of the other risks. So he's got some sharp knives at home. So Tom's kindly agreed to go back home with Jack and remove them from the house. And we also know he's on an antidepressant, and we know how in any older person, any medication can be very, very dangerous in large amounts. So Tom's kindly agreed to take those off him and visit him daily to give him his tablet. And I would say when we see older people, we do ask them specifically about strangulation, because it is one of the most common causes of suicide. And strangulation, of course, well, I say of course, it does include hanging as well. But this is something that I've done with people in EDs before, is actually get people to remove plastic bags from their house that they might be thinking about putting over their heads. And again, sometimes you might not have 3 things to limit the risk there. So the things that he can do by himself is that he can at least go down the shops and back, and perhaps have a sit on the bench outside Coles when he gets to the shops, because you often see people sat on their own, just seeking out that, what appears to be seeking out that connectivity. He's got a journal, and that can be very useful because you can go through it with him if he's agreeable for you to having a read with him, to look how things have been travelling. And of course he can reflect on that himself. And he's got relaxation CDs, so he can use them again as well. Because he's a swimmer, he can go to the swimming pool and again be around people. The safe haven's actually in Dubbo and Park, so he lives in Dubbo, so he's very lucky. He can pop in. It's open Monday to Friday, 8:30 to 4:30, I think it is now. We suggest people just give them a ring first to make sure they are open, and he can come and sit and have a yarn or a talk. And he can go fishing with his mate Tom, of course. So he's identified just 2 people, and that's good, because we don't want to overwhelm with multiple people. So he's identified, of course, his best mate and his brother, and he's got his numbers there. These will all be on his phone, but he can have a hard copy up on the fridge, like I say, as well, so he can turn to that when he needs to. And he's listed 4 numbers that we've suggested to him, starting off with MEC and Lifeline. It would be 139 if he was Aboriginal, of course, and Men's Line. And he's got that peer worker, so that's placed David on there as well, because David's got a copy of the plan. So this is where you get to have a go. If I might read this through, but I'm going to ask you rather than tell you the questions at the end, the answers, some of the answers to the questions at the end here. So Ron, he's an older male. He's a retiree, and his mate Arthur's brought him in to see you wherever you work, whatever service you offer. And they've been concerned about him because they found him on a bench in the park, crying his eyes out. And he reports having argued again with his wife, Irene, and she reportedly told him that she'd go and stay with her sister if he continues not to contribute to any of the housework and leaving his dirty dishes in the front room. This has again made him intensely anxious, and he has, as an aside, he has hypertension, as a bit of a carrot for you there. He admits to recent thoughts of harming himself and drinking alcohol most nights, and probably driving his car still under the influence the next morning. His wife declined to join for the review when Arthur called her earlier. But his strengths are that he's got an 18-year-old granddaughter with whom he's very close. He usually enjoys lawn bowls, playing the piano and attending his local church, but he's reduced the time spent on these activities in the last month or so. If anyone's brave enough to unmute themselves, or we can take questions or answers, responses in the chat room. First of all, let's have a bit of a brainstorm around what else do we need to know?
I guess, Martin, I'd like to know about, he's very close to his granddaughter, his 18-year-old granddaughter. When was the last time he caught up with her?
Yeah, I can tell you that he still sees her, but he's just been withdrawn when he has been seeing her. He's not got that look of joy on his face when she does come into the room. What else do we need to know?
Anyone else comfortable enough to speak up, to think about another thing that they might be thinking?
I might give you a little bit of a helping hand, but I will ask you the next three questions as well. But I do again want to know what he's been thinking, and you know, how many beers or whatever he's having of an evening before he's getting in the car, and what time in the morning is he doing that. Yeah, that relationship with his wife, it's not great at the moment, and yeah, I'd like to know what her perception on this is and how willing she would be to support the safety plan. He sounds depressed to me, and you know, that's just a bit of a guess really at this stage in the day, unless we've properly engaged with him and looked at those depressive features or his psychosomatic features. You know, if he's got pain in his belly, perhaps that could be that depression. So one of the potential risks was that he could get in his car, wasn't it? But have anyone got any other risks that you're identifying there? What do you think, Gabe?
I think the other thing too is it would be a worry. What would he think if his wife did leave him? What would happen there?
Yeah, absolutely.
Potential to risks too, I guess, about his physical health. If something did come up during that physical health assessment that was more sinister than just hypertension, but other things that came up, how would he cope if something else showed?
Yeah. The point towards hypertension is that antihypertensives, some of them are ultra dangerous for obvious reasons. Taking too many do too much to reduce the tension in one's heart, and particularly for somebody with a heart problem. And what else would we ask and do?
Any other thoughts from the group think? Happy for you to pop something in the chat if you're not comfortable to chat, to talk.
I would say that no matter how many years have I worked in nursing, I would still be calling someone like the mental health line and just running this by them to say, you know, I'm pretty worried about what's going on. I wonder what you feel about this story. The service is confidential. If you're ringing from outside of health, you don't have to give your name. You don't have to give the person's name, but you can say, I've got someone in my family that I'm concerned about. Can I just talk about them for a moment with you? And lastly, what might go into his safety plan?
I'm thinking, Martin, the things that pop up for me there with Ron might be certainly when you talked about his 18-year-old granddaughter that he still remains connected with, getting in touch with his consent, getting in touch with her and seeing if she's willing to be part of that safety plan. Like you mentioned too, the wife, seeing what's happening there, the wife may be willing, he may be willing to have her as part of that safety plan as some of those key contacts.
Yeah. I'd see the foreseeable change of his wife leaving him, as you say, as being a huge factor. And his reasons to live, he's got a fair few good support there, hasn't he? So we could include all manner of things there, but scale it down to 3 again.
I like too how the safety plan talks not just about with warning signs, those foreseeable changes in the contingency plan. So I guess working with Ron here in this instance to think about what would happen, and who might he talk to, who might he connect with if his wife were to leave him, for example.
Yeah, he's got his mate Arthur, isn't he? So I might put him in there and say, Arthur, could he come and stay with you if his wife, if Ron's wife does leave him? And as I say, the two of you could ring Mac, and because they've got a copy of this plan, you could say one of the foreseeable changes has occurred, and they'd look for that plan to see what that means, and obviously ask Ron what it means to him.
And people have put in the chat there too, Martin. Someone's written, could church be part of the safety plan?
Absolutely. I'm very glad you've mentioned that, because I rattled through family and friends and what have you, and even the next door neighbour, but the church can be such obviously a strong group of people, or he might be a member of another group of people, like his local bowling club. So with his go ahead, as long as he's okay with that, because obviously you're sharing some real delicate information here, you could perhaps find that person in the church that he connects with.
Someone else has mentioned, is he safe to live there with his wife? And if not, where is he going to go to live? I guess that's a really good point too.
Very much. And as I say, this guy definitely sounds depressed to me. So is he safe to remain at home if he's got some really distressing thoughts about ending his life? If that was the case, he might not be. He might need a brief period in hospital if he is majorly depressed. But yeah, if he's not going to be staying at the address, where is he going to stay? And dare I mention it again, the means of him actually finding, say, a rental property are obsolete at the moment.
Yeah. There's also a comment here too about, what about his substance abuse, alcohol and drinking and driving, danger to public, danger to himself?
Yeah, we've certainly got to think, and there are very rare occasions where suicidal people do harm others, but it has happened by misadventure, such as cases like this. And so, yeah, we perhaps would say, well, why don't we give your car keys to your mate or your wife, and not that they're going to breathalyze you in the morning, but they've got a good idea. If you've been drinking since 11, they're not going to give you the keys at 9 o'clock in the morning.
So having that foreseeable change again, the contingency plan of who to share the keys with if Ron is drinking, and it gives him then the power and the control over that.
Yeah.
Great comments, great thoughts, guys. Anything else?
I'd just pick up on the great response about the church and say things he could do by himself. Even if we said to him, how's about you at least walk over to the church and have a sit outside, even if you don't feel like going in at the moment. That clearly is a real source of inspiration and faith for you. And they certainly would be with people and places he could connect with if he was to take that forward.
Someone's written here, does he have access to a piano to play or join a group band, for example?
I'm liking it, yes, because you're concentrating on his strengths, aren't you, rather than saying, well, perhaps you pick up a piano again in the near future, but saying, how about giving it a go? If there is one at home, or as you say, there must be one at the church.
All right, anything else that people can think of or want to ask?
If you go on the Beyond Now app, you don't have to choose that, but it is a validated app through Health. You will see all these the scripts and the suggestions and some info about how to use the app itself. And we've printed off, as I say, hard copies for people. If it's got to the point where you are safety planning with somebody, I would recommend that you do, as I say, contact the mental health line just to say that you've begun doing that. And again, I'm not going to give Ron all these numbers, but I can delete these. I can delete the ones that don't apply to him and leave him with just those 3 people to talk or yarn to and 3 or 4 professional supports. Well, on that note, I'd just like to thank you for hearing me out at 8 o'clock in the evening. It's a big thing to jump online, so I really do thank you for doing so. And I'll hand you back to Katie.
Thanks so much, Martin and Gabe. And look, it's a really tricky subject, isn't it? And it's hard when people are dealing with these situations. So I really appreciate your expertise in this space. And I think knowing that there are all those the MEC there to help and people can call if they've got patients or clients presenting this way is really helpful. If anyone has any last minute questions, please pop them in the chat. We'll just get our evaluation link up. Your feedback is always really welcome. You know, if there's anything extra you need in this space for future learning, we're very happy to look at organising that, and also just feedback on how it went tonight is really valuable. So Erica, I'm not sure if you can share that slide for us. And thank you, everyone. I know it's a long weekend coming up, so we really appreciate that you've taken the time to be here with us tonight after a busy week. And so we really do thank you. And we'll just try and get that evaluation link up. But we will also make sure we send it around in an email afterwards with any resources. And like we said, we're recording this session, so we can make it available to you if you want to review or go over things. Certainly. Here we go. So there's the QR code if you want to just take a second to scan that. I'll leave that up for a little while, but thank you all so much. Have a lovely rest of your evening and stay safe over the long weekend and take care. Thanks, Martin and Gabe. Really appreciate it. See you all. Bye.